today's webinar is going to be an evidence-based discussion on different aspects, both new and old, of trauma management worldwide. And it's adapted for a wide spectrum of listeners who would have a range of health budgets, hopefully allowing everyone to take home some aspects or reinforce their clinical practice. And we're conscious that those listening today, some of us will be trauma specialists, others just doctors with an interest, but we're coming from a whole variety of different healthcare contexts and economic contexts. Dr. Douglas Wilkinson is a consultant anaesthetist in intensive care medicine at Oxford University Hospitals NHS Foundation Trust in the UK and an associate fellow at Green Templeton College, Oxford University. He founded the Primary Trauma Care Foundation, the PTC, in Oxford, and he is also Surgeon Commander in the Royal Naval Reserve. But he's broadcasting today not from Oxford in the UK, but actually from Queensland in Australia. So Douglas, a real pleasure to have you on ICMDA webinars, and we really look forward to hearing what you have to share with us. Thank you.
Thank you very much indeed. Thank you for inviting me. I'm very honored indeed to be involved in your program. Peter, thank you for that introduction. I think it is obviously in trauma, surprisingly new, a few things are new, but at the same time, the few things done well saves lives. And over the next half an hour or so, I hope we can go through some aspects which you'll find of interest. So we're going to start, and I do apologize for the gory pictures, but this picture is something we should never see, partly because this person has no hope at all of survival. And the only reason this X-ray was even taken is somebody has put an endotracheal tube down, and this man or woman is not in a survivable position. But you can see the pilot cuff here, whereas this patient is severely injured, but is still breathing spontaneously. And you would argue that with simple procedures, this person may well survive, not least because there isn't the desire to put an endotracheal tube down in the short term. Right, so in the next 30 minutes or so, and our time is pressured, but I'd like to look at some of the evidence related to a couple of issues which you may find interesting. Damage control surgery, which is not a new concept, but it's surprisingly underused. The use of tourniquets, a little look of blast injuries, a very important one of hypotensive resuscitation, which again is something which a lot of us know about, but I'm not too sure we know the evidence. Blood resuscitation, looking at a little bit of crystalloids, big debate. Recombinant factor 7, we might miss out because there isn't any proven benefit. It's an interesting concept. Haemoglobin, a little bit on trauma systems, and finishing with cervical injuries. So if we're happy to whiz through that, we'll start. So damage control surgery, a traditional steps of surgeons is to be presented with a patient in trauma. We expose the injury, we get source control, we resect the problem, and we reconstruct. The trouble is, and I'm sure a lot of us appreciate, that when we are time pressured and the patient is unstable, and especially if there are other specialities or inexperience involved, we want to or get caught up in one aspect of the patient and the anesthetist, if it's either the surgeon's doing the anesthetic or you've got an anesthetic nurse, the doctor at the top end, you can get caught up in trying to fix the patient or fix the hip or the abdomen and forget that the patient might be bleeding into the head, etc. So there are a couple of warning signs which I think we need to look at to know who is a good patient, to be careful about perhaps doing a limited amount and coming back a second time. So when there is hypothermia, when the temperature is below 35, or there is a bleeding diathesis or disorder, or acidosis, or all of these, then we need to look very carefully that whether we carry on doing surgery is the best, or whether we wait, pack the patient, perhaps keep them in a high care area. Intensive care, very few of us have. But the plan is to do a laparotomy in the short term, to then rest yourself and the patient while we resuscitate the patient to go forward. Now, again, this is a concept which isn't new, but it's amazing how few people will do this, be it at tertiary hospitals, in big centers, or in the rural environment. Now, again, we don't have a luxury in many remote areas to have the facilities to do all that, but in a tired surgeon or an under-researched area, there's certain conditions we need to look carefully to know whether we can be successful and whether we should continue on or whether we should pause or move the patient to a more stable or tertiary environment, if possible. So the high energy blunt torso injuries, the stabbed wounds or the penetrating injuries, major vascular injuries if they are survivable, or bleeding into the abdomen or pelvis, we need to be very careful that what we do is actually going to help the patient. So the bottom line, and we literally are just going to touch on each aspect for damage control surgery, is that we go in, but if there's any sign that the patient is losing blood too much and we haven't got source control, if the patient is acidotic, pH is less than 7.3, most patients start surgery with a pH less than 7.3. So we've got to be very mindful that good resuscitation is vital for good surgery. If the patient is cold or in any way is not getting the right blood products, which we'll talk on in a second, if at all possible, we need to pause, possibly pack the abdomen, wait for a couple of hours till we've gained a little bit of source control as far as giving fluids, resuscitation, getting some rest, and then going back in again. This has been proven to be in the military or in civilian street to save lives. It is resource heavy and depending on your environment, but I put it in right at the beginning because I think it's an area where we often underestimate its benefits. Right, whizzing on at this whiz trip of trauma, tourniquet use. I think a lot of us now are used to it, but tourniquets have been around probably from the time of our Lord onwards, really. But it's fair to say after the First World War, this was the British military's manual written in 1918. The systemic use of elastic tourniquets cannot be too severely condemned. And the reason for that is elastic tourniquets never really were able to get on tight enough. But by the beginning of Korea and then Vietnam, as the battlefield and docs could get closer, or more importantly, get people back to the field hospitals, more and more benefits were seen in tourniquets. So this commander in the military, Tattle, in 1926, gave some basic guidelines for tourniquets, which are still in use today, which is never cover the tourniquet with a bandage that you can't see that the patient's got a tourniquet. Write very clearly that there is a tourniquet on with the patient and instruct the patient, if they are alive, conscious, to let people know. Right in the time of when the tourniquet on has been helpful. Tourniquets are obviously risky and you only use them if it's life and limb at risk. The complications include pain. It's very painful if you're awake to have a tourniquet on, but to be honest, if you are going to exsanguinate and bleed to death, then you need to consider this. Swelling, nerve damage, and of course depends where you put the tourniquet. If you put it over muscle, that's one thing. If you put it over hard bone, like in the femur, well, the tibia or fibula, we have to be slightly more cautious. For old people, atheromatous plaques can cause a problem. The wider the tourniquet, the better. And so certainly the tourniquets which are used today in accident emergencies and in the war environment are usually about 3 to 5 centimeters in width. And we just have to be careful on the application. So in summarize, our use for tourniquets is that no patient should exsanguinate without a lack of a tourniquet. I have many examples of this in our work with primary trauma care and around the world. There's a lot of very good work of looking at landmine victims getting good benefits from putting tourniquets on. It's very important to get hemorrhage control and just be very careful not to put them over a joint, not over close, because you can be surprised how it can decompress the tension and a fair far away from the wounds of the margin of the wound. This should ideally be assessed 6 hourly, but I think we have to be realistic. If you've got somebody who's exsanguinating, it's worth trying. Will it save their life? Not necessarily, but it does stop that exsanguination, the coagulopathy, and the disseminated intervascular coagulopathy, or the DIC, which would lead to the propagation of bleeding. So they're not cheap, and you can reuse them, wash them again. They don't have to be sterile, but I think it's something we should have available. Again, blast injuries, depending where you work, this is essentially theoretical, but I put it in because if you're in an advanced center, you can do something about it. Prevention of blast injuries, like prevention of trauma, is of course the answer, but where we as doctors are often placed in the positions where we are consequential to injuries. So there's not much we can do to prevent these, except look at prevention of wars. But if we look at the primary injury, it's direct overpressure of the blast, and that will immediately, usually if it's very close, the air-filled cavities like your ears, your stomach, your lungs will have enormous pressure. The secondary blast injury is the injury caused by flying objects. Tertiary, it's features by high energy explosion caused by the individuals flying through the air with multiple injuries associated. And then the quaternary, or the last one, is the injuries related to blasts, which are crush injuries, smoke injuries, etc. What can we do about these? Well, in a sense, there's not awfully much you can look at them and do much about. There was some work done by the Israelis looking at if you ruptured your tympanic membrane, that could give you an indication whether you're going to have abdominal or lung injuries. But because the structure of where the blast injury happens is so variable, it's almost impossible to objectively look at the body and say this was an injury that can cause problems, because underwater it'll be worse, confined spaces. But if you're in the open air detonations, you could be quite close but not be exposed to it. And likewise, a lot of blast injuries from mortars or even anti-personnel vehicles or unexploded devices go upwards. And it's amazing how close people can be if they crouch down to miss a blast. So tympanic membranes are not necessarily helpful. Now, again, this is a very advanced slide. If you've got the facilities, you really want to get your bloods off. Carbon monoxide and cyanide is not really an issue. The important slide here, just read for white phosphorus, for people who are involved in the war areas. A lot of these explosives has phosphorus in them, and although you can wash them out, if you do have copper sulfate, again, these are wish lists and we have to do what we've got, but I know I'm talking to an audience which will be exposed to a range of facilities. You need to wash these things out. Unfortunately, the tragedy of war is that these injuries are devastating. So blast injuries are something we're going to come across. The tertiary blast injury is a thing people themselves flying through. They may not necessarily have any obvious evidence of the blast, but they'll have bony and abdominal injuries from being thrown through the air. This is a topic that I think is very important. I'm going to spend a little bit of time on the evidence, and you could say that this is not new. In fact, this is 1994, but I'm amazed, whether it be in Oxford, where I've been working in different parts of the world. It's amazing how people forget this and the evidence. So this study by Bicknell in 1994 was looking at the effects of delaying fluid resuscitation until you've got source control. Now, we take this for granted, but this actually changed ATLS guidelines, it changed the military guidelines. And this study looked at 600 people with penetrating abdominal injuries who presented with hypotension. Now, that's quite bold, and I don't know how they got the ethics permission, but what they decided, they designated a control and active arm. So they put the immediate resuscitation group receiving standard fluids. Now, in 1994, that was a couple of big Ventflons and a couple of liters of Hartmann's fluid or normal saline, normally a crystalloid. So that was the active group. And those aside, the second group was the delayed resuscitation group, receiving intravenous cannulation but no fluids until they reached the operating room. Now, for a person with abdominal injury who's hypotensive, most of us would want to give fluids. So this was unbelievably this is again in 1994. So that was a massive proactive move 20 years ago, 30 years ago. So looking at the data, they basically found there was a statistical benefit in survival in the delayed fluid resuscitation group. In other words, people who got no fluid and were hypertensive had a better outcome. And likewise, looking at the intraoperative blood loss was a similar in both groups. And those who'd received the delayed resuscitation fluid, they had less complications, but not statistically significant, than those who were given free amounts of fluids. So that you might say, well, that's a once-off. Now, I won't bore you with going through these, but there's a lot of evidence that looked at all this. For example, this was a couple of years later by Capone, who looked at the surgeons, very interested, attempts to achieve normal blood pressure during uncontrolled bleeding, increased blood loss, hemodilution, and mortality. Because literally, you just flush out all the clotting products. And the hypotensive resuscitation group results in less acidemia. So this is huge. And again, I've looked at this extensively, many people have, which led to a consensus discussion in the UK by 2002 by Ravel, who basically got all the colleges together, well, a lot of the colleges together, to look at a consensus management. And this is what they came up with, which has become part of NICE guidelines, which is National Institute of Clinical Excellence in the UK, that basically said for people in the pre-hospital environment, no fluid should be given if the radial pulse can be felt. And of course, as we know, the radial pulse is present from about a systolic pressure of 70 or more. And if you do not get a radial pulse, you should give 250 ml boluses of crystalloid with regular reassessments. Now, what does this mean for us in trauma? Well, first of all, and I've spent a bit of time of our very limited time looking at this, but if I can encourage you to think about this, the bottom line is you should not be fluid resuscitating people or giving them blood until you have source control. Hence the tourniquet, hence getting to the surgeons who can actually put a clamp on. If this is not possible, that's fine. But the overwhelming evidence is that you do need to get source control before you give fluids. The next thing is, well, what kind of fluids do we give? Well, I think this is an interesting one. There's been a lot of work in the military, and that's also rolled over into civilian streets. And basically, casualties received a lot of blood in 24 hours, had a much lower mortality, vastly significant, 20% versus 65, if they gave basically whole blood resuscitation. Now, historically, we've just given, when the blood pressure drops, we give them crystalloids and then we give them packed cells. And people who have massive blood losses, those group of people did very badly compared with giving them FFP, packed cells, cryoprecipitate. Now, for those of us working in the rural areas, this could be pie in the sky and utopia. Now, as we know, the WHO onwards we've always now had to give fractionated blood. So to save money and to store blood, we fractionate it into different components. But the Israelis have shown very, very good benefits on giving whole blood. And if you're in a very remote area, and if you've got ABO compatible assessment, giving whole blood is exactly what you should be doing for people with major resus. Now, again, I've given these to people, and hopefully they'll be able to, the translators, be able to get you to the studies. But I don't want to go through this with time, but it has been shown repeatedly that if you give 1-to-1 ratio of packed cells to FFP, your survival for massive trauma is significantly better than just giving packed cells. Okay, so this goes on and on. So I don't want to spend too much time with that because I'm appreciating our time is very limited. So you could say, well, that's in the military environment. Now, a lot of us are involved in trauma, but is this the same with obstetrics, for example? And this editorial in the obstetrics journal in 2007 basically suggested the same. So major trauma packs should have red cell packs, fresh frozen plasma, and platelets. And I'm going to talk a little bit about clotting, but we do need platelets. If platelets drops, that's where a lot of your clotting products are, and you do need to keep your platelets up. Cryoprecipitate is the top part of the FFP when you thaw it. So you can, if you're giving proper FFP, the need for cryo is reduced, but I will talk a little bit about that. So if possible, and I know all our resources are limited, giving the correct amount of fluid in the form of a balanced blood transfusion is essential for resuscitation of a trauma patient. I'm going to use this as an example because I did a little study looking at people's understanding of hemoglobins and what happens when you bleed. Now, I can't see you and I can't ask you a question, so forgive me. This is a patient, an average patient, an average adult, because children are slightly different, but an average adult will have 5 liters of blood volume. Let's say their hemoglobin is 100 or 10 grams per deciliter, depending on your scale, and the clotting is normal. So this is a normal adult. He then walks straight outside and gets his leg blown off, or somebody cuts his arm off, and he bleeds out half his blood volume. Okay, are you with me? So he's gone from 5 liters to 2.5 liters. The question I want to know is, what is his hemoglobin? Is it 100, or is it 50, or a variation thereof? Okay. The hemoglobin in the acute early stage is the same as when he had 5 liters of blood. The only difference is his intravascular volume has reduced. So if you take a full blood count or you do a needle stick to check the hemoglobin after somebody's just had an accident, the hemoglobin might look pretty close to normal. And likewise, the clotting in early stages, except for fibrinogen, which if we've got time, I'll talk about, is relatively normal. And I think this is where a lot of people get confused. They have a patient who's bled out or has fractured their pelvis or has got a femur fracture, and you can lose 1.5 liters of blood in a femur or 2.5 liters in a pelvic fracture, and the patient doesn't look like they've bled at all. You then take the hemoglobin and they've got a tachycardia and they're hypotensive, and the hemoglobin is still normal, and you think, oh, they're not bleeding. But of course, the problem is not that they haven't bled. It's a problem the intravascular volume has shrunk down to that. And the hemodilution of clotting and the hemoglobin is reduced depending on what fluid you use to resuscitate the patient. So as you then resuscitate, and I'm so sorry this is a one-way traffic, but as you resuscitate the patient, if you use crystalloid, you are going to cause a reduction of the hemoglobin. As you resuscitate the patient with whole blood, you will re-expand the hemoglobin back to normal. So the biggest problem, I think, in trauma and assessing hemoglobin is that we do it at the inappropriate time to assess intravascular volume. And that is the secret. Giving blood or having all these checks of clotting profiles or tags, etc., all depends where you are in your resuscitation of the patient. So as you resuscitate this patient back to his normal intravascular volume, if you just use crystalloids, that's when your hemoglobin drops. And a lot of us who have done surgery know that the next morning after you've done a hip replacement or a laparotomy, the hemoglobin during the operation was fine. The next morning, it's dropped 2 or 3 grams or 30 in new terminology, and you think, good Lord, this patient is still bleeding. They're not necessarily bleeding. What you've done is you've had to resuscitate them, and they have hemodiluted themselves. So I hope that sort of comes across. Moving on. Saline, friend or foe. Now, a lot of us only have saline, but there was a lot of interest in the last days with crystalloids or colloids. And what we do know is the studies have shown there's not a huge difference. And in fact, most places have moved away with giving gelafuscin starches now, because actually there's increased evidence that these are dangerous to people. So in the UK and in Australia, we have moved away almost entirely from the crystalloids and the colloids and the starches. Is saline particularly effective compared to normal saline, compared to Hartmann's? Well, Hartmann's or Ringer's lactate depends, is physiological saline. But in this particular study, the SAFE study, they looked at resuscitating people with saline or albumin, but they found that there was no increase in survival as a result of using colloids. Now, if you want to get the physiology of this, this is Peter Gosling wrote this quite a long time ago, but it's a very good understanding of the physiology of different fluids. And again, we haven't got awfully much time here, but this is a study looking at a couple of medical students or groups of medical students where they basically used them as their own control, and they gave people normal saline or 5% dextrose, and they then the following week they brought them back and they checked the same medical student with different fluids. And they found that people given 2 liters of saline rather than 2 liters of 5% dextrose ended up by retaining a lot of fluids, and the saline group showed a fall in albumin concentrations. So basically, the challenge for us is to use whatever fluid we've got once you've got source control, ideally giving whole blood if you can, to give reconstituted blood, or if necessarily give crystalloids in that mix, but bearing in mind the half-life of both normal saline and Ringer's lactate is 20 minutes. So in other words, if you give a liter of fluid intravenously, within 20 minutes, that is only amount to 500 mils intravascularly. The rest of it's immediately leaked into the interstitium. So going back to normal saline, and I'm not keen on normal saline. I think it's good for diabetics, for very bad diabetics. And if that's all you've got, that's fine. But normal saline is not normal. It's unphysiological. And if you have Ringer's lactate or Hartmann's, the bottom line is use those as your first amount of fluid. So far, and I'm aware time is ticking by, we've looked at the need to keep the blood pressure low until you have source control and you can stop the bleeding. We need to be careful just using a hemoglobin. And when you do give fluids, if you have a lot of blood loss, you must give blood back rather than just pack cells, because your mortality will go up. Some of us have the luxury of using hypertonic saline. So out of all the colloids, and hypertonic saline is defined as a colloid because it acts by pulling fluid back into the interstitial or the intravascular space. Hypertonic saline is used less and less. There is some benefit in head injuries, but it hasn't been shown to basically improve outcome. But we often use it while we're biding time. But if you're in a remote environment and you have a head injury, these are academic issues. Peter, I'm aware time is marching by, so I just want to whiz through a couple of these slides, and maybe these can come out to you. And factor 7, the long and short of it, has not been proven to be helpful. I'm just going to look at this now. This is all us for medical students. This is boring stuff. Old and things have changed a lot, but you still have essentially the intrinsic and extrinsic pathway. Clotting is much more complicated these days, but the building blocks, and you see where factor 7 comes in, it feeds in, and that is carried in platelets. And that's what I want to basically say. You need platelets for factor 7. And that allows factor 10 to go to 10A, prothrombin to thrombin, fibrinogen to fibrin, and then you get clot. Fibrinogen is made in the liver, and we'll come to that in a second. This was a study looking at a Johannesburg Baragwanath Hospital, looking at recombinant factor 7. Should we be giving this? Is this the magic bullet? Anyway, a lot of money was spent on it, and it has no benefit except for passively reducing the amount of blood you give. But mortality has not been improved by giving it, and it's not carried even by the Americans. What hemoglobin should we settle with? Well, I think we know that we can accept rather low hemoglobin. There's a very good book called The Clinical Use of Blood, which basically says there's all sorts of benefits of having your hemoglobin drop to that. And a lot of us working in the rural environments know that people can often function extremely well with hemoglobins half that. There's all sorts of 2-3 DPGs. They're shifting to the right of the curve, which the body does automatically with chronic anemia. When you get to trauma, sometimes we, especially if they're repeated surgery, we do like to get that up, but sometimes this is utopia. And we've talked a little bit about the clotting and the pH related to good source control. Nearly finished with this. Fibrinogen is an interesting one. And again, there's a thing called the thromboelastogram, which a lot of people are trying to find a use for. I'm not a fan, because if you're giving proper balanced fluid resuscitation by giving FFP and PAC cells in the appropriate balance, you get enough fibrinogen. But fibrinogen is found to drop very quickly. It's one of the earliest clotting dysfunctions. Even within half an hour of injury, your fibrinogen is starting to be depleted. So we do like giving that if you've got a limitless supply of funding. You can find it in FFP, cryoprecipitate, and fibrinogen degradation products. The nice thing about this, which very few people can afford, is that it has a long storage life. It doesn't have to be controlled with temperature. It can be kept on the shelf. This is something for those who want to look at the clotting. Normally, we just do bleeding times or APTTs or PTs or INRs. This is slightly expanded. We used to do this for cardiac surgery, but it's bubbled over into trauma. Looking at this, and all you do is you put a bit of blood in and you spin it, and then have a little needle in it. And as the clot forms, it creates a sort of bullet or a condom looking thing. And then for those who believe in this, you can draw a lot of evidence looking at how long the clotting works and how big this clot formation is. And people have made quite a bit of science out of it. I don't want to bore you too much. I personally think it all depends on doing the things properly. And I think if you're resuscitating with whole blood or reconstituting with whole blood, that's the answer. Trauma systems, I think we all have what we have. My interest was looking at primary trauma care. And for those who want to be involved in that, it is there. We don't have too much time to look at that. I'm just going to finish, Peter, if I can, looking at the consequence of doing proper debridement. Again, I do apologize for this. This person stood on an anti-personnel mine. The bone's hanging out. The only reason they're alive is this tourniquet is on. And the surgeons just repeatedly cutting back until you've got something that resembles somebody who's not bleeding anymore. You can see the bones cut up. This person will need ongoing debridement. Most of us in resource-limited areas will not be able to do this. People will unlikely to survive, but in the military, they do have these capacities. But it is vital that we never close these wounds. I'm going to finish with cervical injuries. Cervical injuries are sort of academic for us in the rural environment, because people, if they do have neurological injuries, it's going to be a terminal event. For those who like numbers, 7% of head-injured patients have cervical injury, which is sort of 1 in 12. 50% of patients with fractured cervical spines have spinal cord injuries. 50, okay? 50% of spinal cord injuries have head injuries. And spinal cord injuries may not be mechanical, but perfusions. And certainly if we're looking at, and for those who work doing spinal surgery in developed countries, you'll be aware that the surgeons need to put the head in a position, and there's a fair bit of moving, and sometimes you have to put a breathing tube down. So clearing of the neck is very difficult, and if you haven't got x-rays, the best thing is to absolutely wake the patient up, because if a patient says they don't have pain and they've got good sensation, the chance of missing an injury is 1 in 30 to 1 in 300,000. It's very low if you can talk and the patient does not complain of pain. Whereas if they're asleep, then your chances of missing something is significantly higher. But open to questions. Thank you, Peter.
Thank you very much, Douglas. And wow, that was incredibly comprehensive in such a short period of time. And as a surgeon myself, but who's been out of clinical practice for some time, it was most illuminating to see how an evidence-based approach has impacted upon the management of major trauma in quite an amazing way. And I'm horrified, having heard your presentation, to think of some of the things that we used to do in good faith 30 or 40 years ago, and how many of those myths have been overturned. But the way you've explained it, it all makes very good sense, and one can see how important research is in terms of informing this. And I guess the whole area of trauma is very much on our minds at the moment, certainly in Europe with the Ukraine war going on, and trying to, as ICMDA is doing, equip doctors on the front line to be able to look after these things. So very, very interesting. Thank you very much. I wish we could have given you more time, but we have got time for questions. The first question here is not directly related to trauma, and as they say, you might not feel yourself qualified to comment on this, but with regard to resuscitation in postpartum obstetric hemorrhage, do similar principles apply as those you've outlined?
Yeah, that's an interesting question. I think when the military were doing a lot of this work, the question was, is this relevant to the civilian society? And the obstetric editorial did look at this, and certainly, although it is different because you've got uterine atonicity and they're varying elements, the idea of resuscitation and certainly assessing intravascular volume is appropriate across the board, general surgery as well. So that editorial with the, I think it's the UK Journal of Obstetrics and Gynecology, did endorse the need for major blood resuscitation packs, which carry 4 units of FFP, 4 units of packed cells, and I think 1 pooled platelets, which has either got 4 or 6 pooled platelets, because that basically reconstitutes whole blood, which has been found to statistically be beneficial to survival. Yeah.
In a low resource situation, Doug, where people may be dealing with major trauma, but don't have access to packed cells, FFP, and platelets, what should they do in terms of resuscitation?
Now, I think this is always the tricky one. I think, so basically allow the blood pressure to drop down, because there's overwhelming evidence of people auto-coagulating when the blood pressure is low. And I think the concept of getting the blood pressure up has been proven out. So you could keep the blood pressure low, get damage control, source control. I think, you know, if we've got ABO and you've got family who can offer blood, whole blood directly from the population, which is warm and compatible, is by far the best. Unfortunately, in the Western world, it's almost impossible to get this. But family ABO compatible whole blood is the perfect resuscitation fluid, yeah, if possible.
Doug, we hear a lot about hemostatic agents on the front line. Would you like to comment about those?
Well, again, the American military have spent so much money on these things. I mean, ever from Vietnam onwards, and they are pretty procoagulable powders that can use. Certainly, in my experience in Iraq and Afghanistan, is in theatre they didn't use these things. I think putting them topically, they just get washed away. I think the way of getting source control of tourniquets and actually getting surgical intervention has been, with this full blood resuscitation, pretty much dominates. I think there is, I mean, for example, I cut out a big section of time on synthetic hemoglobins. Now, there's a very interesting thing, because you don't have shelf lives and anything else. They're in phase 3 study trials. They are coming, but they're not as good as the real thing. So no, I think these powders haven't, in my understanding anyway, I'm happy to be corrected, have not shown to be necessarily beneficial.
Thanks. And with regard to tourniquets, and certainly the thinking, as you've outlined, has changed dramatically on these. You talked about the distance from the wound, the width of the tourniquet, that make sure you put them under clothing and so on. Of the tourniquets that are commercially available, are they all of pretty good quality, or are there some that you should prefer over others, particularly in military situations?
Yeah, you can. I've looked at our civilian one in the UK and here, so they're very similar now. They're about, I'm so sorry, I actually have got one. I can't really show you, but I haven't got it here. They are essentially, they're not elasticated. I think that's the first thing. They are, they're pretty much as stiff as you can get. And then there's a Velcro with a little bit of a ribbon, but the tension is held by Velcro, which even if it's full of blood will hold. And then there is a very small, about 3 inches, that can be concertinaed up by using a piece of twig or a piece of wood that you can buy with a plastic. It comes with a plastic like a pen. And so you put it through there and then you just twist it. So you get as tight as you can by pulling this, put the Velcro on, and then you twist until it's very, very tight. And I'm sure there are good and bad ones on the market. The ones you want is there should be no give at all in the basics, except for this ridge, I'm not describing it very well, that basically is used to tension up the 2 hard pieces to pull it tighter. You need to, they're not cheap, unfortunately, but they are reusable. Just wash them and they can be used again. Yeah.
Question here about the use of tranexamic acid in hemorrhage as a result of acute trauma.
Absolutely right. Yeah. In fact, my apologies. I had a whole section on that, but I sort of kept that out. Yes, some of the fibrinolytics have been done away with, but tranexamic acid is momentum, and giving a gram as soon as they come in, and then at least another gram while you're fiddling around. So yes, it's very topical. You don't need to do a test empirically unless there is a known anaphylactic or anaphylactoid response, which almost never is. It is very much in vogue at the moment. Yeah, good.
If one doesn't have a professionally made tourniquet, can a sphygmomanometer be used as one?
Yes, I mean, Beer's block, you know, a Beer's block tourniquet would be superb. I mean, certainly in theatre, you could use those. In the community or paramedics or family bringing in landmine victims, obviously wouldn't have that, but absolutely, as long as the tourniquet, well, even if the pressure does relieve, you'll just get bleed through. So yes, you could use that. Yeah.
Question about the risk of HIV in areas where HIV is prevalent and there may not be time for screening donors. Would you still prefer blood for fluid resuscitation as against crystalloid?
Look, I think that's a good question. I think it is an ethical one, but as clinical doctors, we are faced with compromises, and you know, if it's a family link, you know, the patient might have HIV as well. Ideally not, but you know, we have to live in the world of reality. And if somebody's bleeding to death and they're not going to survive, they probably won't. I think we have to give ourselves permission to basically accept that despite our best efforts might be futile, and that might be a step some people don't feel they can go down. I think that's realistic. You know, I don't think anybody could pass judgment either way, because you have to do what you've got to do at the time.
Yes, we've got one question here that I think probably a lot of people are asking, which is thanking you for the detailed and comprehensive presentation and asking for a copy of it. And just to reassure people, we will make available to you, if you've booked for this webinar or been here today, a copy of the presentation in PDF format. So when we write to you with a link to the video, which will be available again on our YouTube site, we will send you a copy of that as well. Just a question. We're certainly involved in, or from involvement in Ukraine, you see a lot of the approaches now are pretty much protocol driven to trauma. Do you have confidence that those writing the protocols, that organizations like WHO and so on are really up to the minute in terms of an evidence-based approach to this? Or is the knowledge that you've shared really just known to the very best practitioners?
It's a fair point. I mean, the WHO, I mean, a couple of us in Oxford have worked with the WHO, and I think I mean, there's a book called Surgical Care at the District Hospital. It is now dated, but a lot of the basic resuscitation guidelines are there. There is ongoing, I mean, I've trawled for example, the Journal of Injury, and there's all sorts of looking for later stuff, and you'll be amazed how little really new stuff there is. I mean, there's some aspects on transexamic, and there's a lot of interesting looking at how you assess coagulopathies, etc. I think, yeah, the broad brushes and what I've covered is essentially a synopsis of that sort of management. Keep the blood pressure low, get source control, understand my experience, and this is not a criticism of any organizations, but I am staggered at the level of understanding or lack of understanding with things like that hemoglobin. That diagram, I've, as I say, from consultant level to medical students and nursing staff, don't get that's a concentration. I think those little things catch us out. If protocols are talking along good, sensible lines, protocols I don't like the word protocols because I think they can bind us. I think guidelines are helpful. And if you go on the internet, every province in Australia seems to have their own trauma guidelines. You can pick up the ATLS, Primary Trauma Care has theirs. I suspect they're all singing roughly the same tune. I think this issue of giving blood, whole blood, is all coming quite vogue. So I think if you look at the guidelines, they should reflect roughly what we've talked about today. Yeah.
You've talked very much about the importance of source control and early surgical intervention. For paramedics or perhaps even medics on the front line who are dealing with critically injured patients, especially from war injuries, but some way from the hospital, what are the key priorities in terms of maintaining life in that situation?
Absolutely. So I think getting IV access is important. So, that study from 1994, which that's 28 years old, it still sort of holds. So getting IV access, resisting the desire to pressurize fluid. So I've seen this so often. People are bleeding and they'll get IV access and they'll get some normal saline and just squeeze it in because the blood pressure is very low. I think the aliquots of 250 saline, and it's very hard to stop people doing that. The aliquots of 250 saline, in other words, if your blood pressure is less than 60, you're going to exsanguinate. So giving small increments while you are picking them up and putting them in the taxi or in a Jeep or something is not unreasonable. I think well-meaning people often will cause, and this is so sad, but over-resuscitation just lets people bleed out. Because what happens is the clotting starts to go, and then even with, with a normal or even low blood pressure, people will just exsanguinate. And unfortunately, many people die before they get to theatre of well-meaning people who are perhaps don't understand the basic physiology. And I think that's what we're trying to address. So hard that people who aren't surgeons to do it. I think tourniquets, immobilizing, I haven't talked about that because that's sort of not new either, but immobilizing fractures is vital. You will overwhelmingly pelvic binders, even if it's wrapping in a blanket. Stopping exsanguination is helpful while you get there. But the reality is that people sometimes just need to be made comfortable because they often bleed to death in transit.
Douglas, I wonder if you could just say a little bit, I'm conscious of the time here, but I wonder if you could just say a little bit about the work of the Primary Trauma Care Foundation that you're involved in Oxford, and especially what you're doing in terms of education around the world.
Peter, thank you. Well, a couple of us around the world from Oxford, Australia, basically tried to take the good evidence of ATLS and the big American things, and then synopsis it into a 35-page trauma book, which is just the basic things done well, which is sort of what we've been talking about. The website of primarytraumacare.org will get you onto our website, or just Google primary trauma care. Annette, our administrator, is actually retiring, but you will get a response if you write to them. And the material should be free. It was initially. I've now stepped down. I'm just the founder now. But we've got very good people who will be able to give you the stuff. And it's basically, the material is similar to this. What you do to get to the simple things done well, chest drains, etc., are all helpful. It still is, we aren't big enough to offer resources and things, but it is a self-help. It's translated into many languages, and I think we're in 80 countries around the world. So you should be able to get in a language that's close to you, and feel free to use it and disseminate it. We encourage countries to take it and adapt it to their own environment. And it is a joy for us for people to take and run with this, because people know their own country, their own resources, and we've never wanted to impose any system on anybody. So it is very much a resource free for all to everybody. Yeah.
Thanks. We'll make sure that we include a link to that in the letter that we send out to our participants afterwards as well. And we're almost out of time, Doug, but just one last question. Do you feel that the Christian faith has something extra to offer, both in managing trauma as a doctor and as well as adjusting to its effects as a patient?
Well, amen and amen. I couldn't agree more. What is very interesting, that people who are involved in setting up primary trauma care, Mike Dobson and others, have a strong Christian faith. The chairman has just retired, James de Courcy, had a strong faith that this was something that we as doctors can share. I personally was very keen to be involved in Africa, with my home being in South Africa. And these are little steps that I feel we can help. Is the Lord in all? Thank goodness he is, because I think we're going into a darker time, not just in Europe. And I think if the Lord is not in control, we are indeed to be pitied. But despite man's efforts, Christ and Christ crucified is our hope. We as Christian doctors go every day to work with the Lord. And I think he uses us in our education, our faith, to demonstrate that we may not be able to pray with everybody while we cutting them open or we're saving them, but the Lord is our maker. We are his servants, and the Lord gives and the Lord takes away. I have found it easier to deal with difficult situations like that, knowing that my Heavenly Father is guiding me. And of course, we learn more from our mistakes than our benefits. And in those dark times where we feel we could do more, and there's a lot of the Satan is accusing us of failing, we need to hold strong to this faith, because we are finite and the Lord is majestic.
Well, amen to that. And what a great note to end on. So thank you once again, Douglas Wilkinson, for sharing your insights, giving us your time, and even in the little time that we were able to give you, for covering so comprehensively such a complex and growing field where things are changing and where we need to be totally evidence-based, and for your courage and wisdom as well as a Christian in this area. So it remains to me really just to say thanks again. Thanks, Doug. Thanks all of you who've turned up today. Thanks for your questions. And we look forward to seeing you again soon on ICMDA webinars. God bless you.